I'll request Dr. Nithin Varma to speak on screening of diabetic retinopathy in timers list. Dr. Nithin Varma is a presidential guest. He comes from Australia, from the region of down south Australia. He's the president of RANSCO and has published various papers in number of journals, and he'll be speaking about screening of diabetic retinopathy.
Well, thank you, and thank you for inviting me to talk about. I promise I won't show you an OCT and I won't show you fluorescein angiography, but I really talk about the challenges of setting up a diabetic retinopathy screening program in Timor-Leste and or East Timor. And you might ask, where is East Timor? Now my thing's not moving forward, so I try once again. We are stuck. All right, here we go. Okay, we'll start again. That's right. So Timor-Leste is near the northern tip of Australia. It's between Australia and Indonesia, and it's a country which is very small, only 1.2 million people. Its capital is Dili, not New Delhi, but Dili. And it has mainly people who are Catholics, and I'll tell you why that's important. Timor-Leste was ruled for 475 years by the Portuguese, then 25 years by the Indonesians, and it's only recently that they became independent after a referendum. And during this referendum, the country was completely destroyed, and then the United Nations came in and so on. So this is important because where we start from is a post-conflict country where every facility, be it governmental, non-governmental, was razed to the ground. So it's like ground zero. And we started the program in the year 2000, so that was 22 years ago. And the first 4 years were spent on concentrating on cataracts and uncorrected refractive errors and whatever was left behind after the referendum. And then we worked from 2005 onwards on the rebuilding phase, which included infrastructure and so on. So what you're seeing here are pictures of their National Eye Center and how work carries on in between. Here you see some of the registrars or some of the trainees within the center. And also this is supported by outreach in 13 districts where the eye program has now permeated. So again, that's the spread of the eye program. One of the highlights of working in East Timor was the ability to start a training program there at the diploma level, and you see here a very colorful convocation ceremony. But all this is fine. What has the impact of the program been for the past 10 years? So the prevalence of blindness has come down from 7.7 to 2.8%, and that sort of says it all. But that has been concentrating on cataracts and uncorrected refractive errors, which is the way these RABs work. Timor-Leste today is very vibrant. It's a bit like what Bali used to be 20 years ago. The demographics are changing. You get people living longer, and along with that has come the problem of diabetes. Now, a number of studies, especially in the early days, have shown that the prevalence of diabetes is around the 4.6% mark. A hospital-based study found that patients who were not diagnosed as diabetics coming to the hospital, that many of them actually had advanced disease. So much so there was no facility to do anything about these patients, and many of them had to be sent overseas for treatment. So it was a situation where most people would present with one eye lost, the other eye with proliferative eye disease. And in fact, the eye care nurses and the eye care workers didn't think of diabetes as a thing to worry about. I mean, if you didn't have a cataract, you didn't have a problem. So you can see that the problem is more than just screening, because the primary system was weak, the tertiary system was weak. There was no way you could do anything for a patient with diabetes or diabetic eye disease, and things were they were changing. The more and more diabetes coming in, we weren't able to do anything for it. So much so that all the physicians thought, what's the point of even referring them to the eye people, because nothing can be done. So it was a one-way street. You had a problem, and they didn't, the physicians wouldn't refer the patients on to this thing because the results of treatment were nothing like the treatment of cataracts. However, things have changed now, and we have been able to establish a vitreoretinal service in the capital, in Delhi. We can handle almost all parts or all stages of the journey so that we are now really ready to be able to do something about people with diabetic eye disease in the country itself. Also, healthcare is nationalized and all treatment for people is free. 1,000 doctors trained in Cuba have come back to Timor-Leste and have been posted to all parts of the country, so that they've gone down to the village level, and 94% of the Timorese population is now on a national database, so that we really know what's going on, and we can integrate with primary care. So as I said, 94% of households are there, and what you see here is a photograph of a district health center. And I think now is the time, which is a couple of years ago, for us to start screening, because we now have facilities to diagnose diabetes using the HbA1c machines and using the models that have been working in Bombay, and Dr. Natarajan was very kindly allowed us to use these videos and give us a lead with some of the partners supporting us in this. We decided to go with the Remedio camera, which was even smaller, and allow us to reach the periphery where these patients are. Here's the camera itself and the back of the telephone on which all images come. Here's the camera working. It's a very light camera. It's easy to transport and gives reasonable results. So what we have now is we've been through the learning curve, and the company has been very good in sort of helping things out from a distance. So remote troubleshooting is possible, but the teaching and training continues. Here are examples of some photographs, maybe not as good as the ones shown earlier, but they certainly give us enough workable images. The database, and of course some challenges remain because the internet is very slow and we can't upload to the cloud, and they said it's AI enabled, we really don't need it. So we sort of continue working on those issues and also work on the awareness program. That is the weakness, or that's the weak point of the program itself. We need to pass a message on saying diabetes causes blindness and we can do something for it. Just these two lines. But all this is good because if we don't engage with the government, and it's a democracy, so parties come, parties go, and the priorities could be different. So I had to work out how do we future-proof this program. So I suggested to the Prime Minister and to the Health Minister saying, why don't we make a 30-year program? These 5-year programs are no good. So after much discussion, we launched the 2050 National Eye Health Program in Timor. So that's one of the few countries in the world that's thinking that far ahead, so that any political party that comes, eye care, diabetic screening is all embedded in the national budget. So not only that, the training of ophthalmologists is all set up, the training of optometrists is all set up, integration with primary eye care takes place, new health centers have been opened or surgical centers have been opened, and really the whole process is now complete. It's all about the patient's journey. You dare not screen for something if you can't do something about it in the end. And so by 2025, we'd have a higher diagnostic rate for diabetic screening, and by 2030, hopefully, it'll be even better. We use every opportunity, such as World Sight Day and so on, to be able to push this one message about diabetes causing blindness and diabetic blindness. If caught in time, we can do something about it. Health education is important. And now we come to this fact that 94 or 95% of Timorese are Catholics. We have not used, and we don't use in many parts of the world, the religious institutions. If the priest on Sunday Mass, where most Timorese go, says diabetes causes blindness and something can be done by these eye doctors, I think it's a very powerful message, and we've been employing that. The other thing is to use politicians. What you see here is the gentleman with a hat on is a Nobel laureate from 1996, Dr. Ramos Horta, and the other gentleman, not the one in the center, but on the other side, is the head of the WHO mission. And he's been a keen supporter and a patron of the program, and now he's the new president of East Timor. And I tell him, he says, Nithin, what do you want me to do? I said, pass these 2 lines. So this is the total eye health task force in Timor, in this photograph. That's all we have for 1.2 million people, and they can't do this screening alone. The only way a good screening program can work is not with the technology alone, but also involvement of the whole community, the politicians, the government, and the religious institutions. Thank you.
Thank you, sir. Thank you very much for that talk on screening. As far as the Indian scenario is concerned, we do face the same challenges in the villages, and definitely the phone on fundus cameras have been of excellent use when it comes to finding out these cases as whether they have diabetic retinopathy or no retinopathy. Yep. And referring those patients who have diabetic retinopathy to the ophthalmologist would definitely be very helpful.
Yes, I think the important thing is to realize what you're screening for. You're basically, all you're doing is separating the normals from the not normals. I wouldn't call them abnormal, but not normals. And then you've got to deal with the people with findings at a different level, rather than just trying to quantify and say 3 microaneurysms and 4 cotton wool spots. That's not the aim of screening, especially not in countries like this.
Yeah, thank you, sir. Any comments?